everyone. Hello again. Thanks for sticking it out with us. This is the last session, and I'm biased, but I think it's one of the more exciting sessions. Just in general, we've talked a lot about amyloid over the last about 8-9 years, really, when we had therapies, and we have an exciting session for you today. I want to start off by thanking Alnylam Pharmaceuticals and BridgeBio for this independent grant that allowed us to put this session in the next 50 minutes. We'll cover a lot on amyloid. And I would ask you to just think about questions that you may have, because you'll have a great opportunity to hear from experts in the field about how to make the diagnosis and what therapies would be appropriate for your patients. This specific 50-minute program is also being managed by Vox Media, and you probably got at your table a pamphlet and a questionnaire. If you want to fill those out, we'll collect them later on. And specifically, if you want CME credit, there is going to be an online evaluation that you'll have to finish up. Our first speaker is Dr. Ron Witteles. He's visiting us from Stanford University, and he's really one of the leaders in this space. He's been doing amyloid for a number of years, a couple of decades probably, even before amyloid became popular and in vogue. And he currently is the co-director of the Amyloidosis Center at Stanford and also the Sarcoidosis Center. He's well published in this space, and he's mentored many folks, including myself, as we established amyloid centers once therapies became available. And his talk is going to be on ATTR cardiomyopathy, epidemiology, clinical clues, and diagnosis. Welcome.
Great. Thanks so much, Tony. Oh, wow. No applause, please. Anyway, thank you for the opportunity to speak on certainly my favorite topic. And so I get to talk about making the diagnosis and the clues around it. And then Dr. Masri is going to speak about the exciting world of therapeutics. These are my disclosures. So starting at the basics, amyloidosis comes from the Latin term amylum, meaning starch, because pathologists originally thought that they were starch-like deposits. They're not starch, of course, they're proteins. And it's a generic term for many diseases where there's a protein that misfolds into beta-pleated sheets, which stack into 8 to 10 nanometer fibrils and deposit extracellularly, as you can see in the lower right electron microscopy. In the upper right, you see from an endomyocardial biopsy, and the bright pink are the cardiomyocytes, and then the light pink are the amyloid deposits around every cell. The nomenclature can seem intimidating. It doesn't need to be. It's really, first off, there's really only two you need to be aware of, AL, and of course the focus of today, ATTR. And it's just A for amyloid, and then the second letter or letters refer to what the protein is that's depositing. Now, I am going to say just a brief word about AL, not because that's the topic of the session, but it's important to understand it a little bit when you think about the diagnostic testing for ATTR, as we'll get to. So plasma cells, of course, make antibodies. Antibodies are made up of two parts, heavy chains and light chains. Both contribute to the antibody's specificity. The light chains come in two broad categories, kappa and lambda. Now, when somebody develops a clonal plasma cell population, the clone will typically produce the entire antibody, whatever it was destined to produce before it became a clone, and then it will typically produce an excess of the light chain that goes along with that antibody as well. Most of the time, that doesn't lead to any problems. The cells don't proliferate too much in the marrow, and the light chains just come out harmlessly in the urine. But if the light chain just happens to be the wrong structure that makes it prone to misfold and deposit, that's how you can get AL amyloid. And as we'll get to, the biggest mistake, maybe other than not thinking about the disease at all, is to mistake AL for ATTR or vice versa. So TTR, of course, is the main topic for our focus this session. The name comes from its function. It transports thyroxine and retinol, so transthyretin. It's the same protein as prealbumin, so if you send a prealbumin level, that is a TTR level, and it's produced mainly in the liver. As we can see in the diagram in the upper right, it circulates as a tetramer, so 4 subunits bound together. But there's a steady state in any given time with a very small amount as monomers, and it's the monomers that are prone to misfold and deposit. When thyroxine binds to the structure, it stabilizes the tetramer, and when Dr. Masri talks about stabilizer therapies, they're binding to that same thyroxine binding site. The monomeric form, again, it's inherently prone to misfold and deposits, and that's exactly what happens in the wild-type form of the disease. It's the normal TTR protein that the monomers over time misfold and deposit. This accounts for the vast majority of ATTR patients you will see, wild-type. It is clearly more common in men than women for unknown reasons, and this has primarily cardiac and orthopedic manifestations. But in addition, of course, people can be born with mutations that make the TTR protein even more likely to misfold, and that is enriched in specific populations, as we'll get to, and tends to cause cardiomyopathy, polyneuropathy, or both. In terms of red flags, there's a number of them. Of course, the first thing is increased wall thickness. And it really should be there for a patient to have symptomatic ATTR amyloidosis. In AL, not always, but for ATTR, to have heart failure from it, you really should have increased wall thickness. The discordant ECG voltages I put with an asterisk because, again, discordant, not necessarily low, but if somebody has a 1.8 centimeter septum and they have normal voltages, that's discordant. But you cannot rely on low voltages in this disease. Heart block and atrial fibrillation are extremely common. Elevation in troponin, not at levels associated that myocardial infarction type levels, but chronic low levels, high sensitivity troponins of 50, 100, 200 are very, very common because of the chronic destruction of cardiomyocytes. And then the orthopedic manifestations, as I've listed there, I'll show on another slide, are quite prominent, particularly in the wild type form of the disease. Neuropathy, specifically in the hereditary or variant form of the disease, and then demographics. So let's speak a little about demographics. And this is a nice study that's now over a decade old that came out of Mayo Clinic, where they looked at 109 patients who had died, and they had an antemortem diagnosis of HFpEF. But nobody had a diagnosis or really even a clinical suspicion of amyloidosis. And then they had age-matched control patients who had died of other causes, say cancer, for example, and did not have an antemortem heart failure diagnosis. And then they had pathologists who were blinded to the clinical history review and say, are there significant TTR amyloid deposits? And so if you look at the figure there, if you focus on the black bars first, those are the HFpEF patients. And you see by the time they're in their 80s, about 25% or so actually had significant TTR amyloid deposits. By the time you were in your 90s, small numbers, but it was actually more than half. But even the control population, by the time you're in your 80s or 90s, you're talking about 10, 15%. Now, maybe some of these were subclinical, and maybe some of these patients who are obviously elderly and may not have been as active actually did have HFpEF, just not diagnosed related to the disease. Now, we've learned with time that another population where you will see this in high prevalence are patients referred for transcatheter aortic valve replacements, probably not because amyloid is leading to aortic stenosis, but rather if you look at a population of older patients with thick hearts and heart failure, which is the most common reason somebody will be referred for transcatheter aortic valve replacement, you're going to find a lot of it. So this was an eye-catching study that said, just screening everybody referred for transcatheter aortic valve replacement, 16% had concomitant ATTR amyloidosis, and as you can see in the men, it was particularly enriched. 16% is probably an exaggeration. There's a meta-analysis that pegged it more at around 10%, and that probably is about right. But if you think about it, that means 1 out of every 10 patients of all comers referred for transcatheter aortic valve replacement also have ATTR amyloidosis. And it's more common in populations you would imagine. Older, men, those with orthopedic manifestations, conduction disease, very thick septum, and of course the low flow, low gradient physiology that's going to be common in the mixture of the two diseases. Now, the orthopedic manifestations very clearly are associated with ATTR amyloidosis from TTR deposits in the ligaments and tendons. This is not neuropathy. So just because somebody has numbness, tingling, or pain, that's not neuropathy. This is nerve compression. So carpal tunnel is extremely common, lumbar spinal stenosis, biceps tendon rupture, trigger finger, rotator cuff, shoulder pathology, clearly all common. And if you see an older patient who's now developed bilateral carpal tunnel syndrome, it should certainly be a red flag. Now, the hereditary or variant form has two main manifestations, cardiomyopathy and neuropathy. There are dozens, in fact, well over 100 mutations, pathogenic mutations described, and the mutation really dictates the course of the disease. I've listed two of the more common mutations here. A quick word on the nomenclature, because it can be confusing. The V30M and V50M are the same thing. V122I and V142I are the same thing. It just depends on if you're counting a 20 amino acid signal sequence. In Europe and Brazil and Portugal, that V30M mutation is most common. But in the United States and undoubtedly worldwide, the most common mutation is what I'm going to call V122I. And this is seen in more than 3% of individuals of sub-Saharan African descent in the United States. So a actually really common mutation. When you look at the spectrum of disease, again, it could be more cardiomyopathy, it could be more neuropathy, or it could be somewhere in between. V122I happens to cause a mainly cardiomyopathic phenotype. So in the United States, wild type is all cardiomyopathic, and the most common mutation is mainly cardiomyopathic. So it really is mainly a cardiology disease in this country. How common and how important is this mutation? Well, this was a nice study, 7,500 some on self-identified Black participants in this longitudinal population-based cohort called REGARDS, where individuals were followed for a median of 11 years. Okay, look at that. Just having the mutation versus not. Look at those hazard ratios. So for incident heart failure, 2.4. For heart failure death, over 4. And even all-cause mortality, 1.46. Now, the only plausible way that this mutation can be causing any of these things is by ATTR amyloidosis. So it just goes to show how common this is in individuals with a mutation, even if it goes undiagnosed. Another study, over 23,000 self-identified Black participants across 4 observational studies, just overall survival. And you see very cleanly it's about a 2-year decreased survival just by carrying this mutation. Okay, another recent study, this was from our group up at Stanford, was looking at some of the data on delayed diagnosis. So this was a study of VA patients with heart failure and ATTR cardiomyopathy who were diagnosed between 2016 and 2022, and it was looking at delays in diagnosis. So first off, you can see numbers of diagnoses have gone up, and if we follow this past 2022, undoubtedly it would have kept going up. But you'll note that those who had a long delay, which here is shown in green, proportionally hasn't changed. So despite awareness improving, you still have most patients where it takes more than a year from their heart failure diagnosis to get diagnosed with ATTR cardiomyopathy. Remember, these are the patients who got diagnosed. The ones who didn't get diagnosed, we don't know. This is another interesting plot. So the red bars are showing how many diagnoses are being made at that spot. And then the blue bar is showing the average wait, average delay between the heart failure diagnosis and the ATTR diagnosis. And what you can see is that places that diagnose more patients might have much shorter waits, or much shorter delays, which is just getting at once you think about the diagnosis, then you start making it a lot. Okay, now the diagnosis is easy, but there are pitfalls. So usually we get the hint, of course, from imaging, usually from echocardiography. And it's, again, the thing that should jump out is when you see increased ventricular wall thickness in the right demographic population, which is really just older patients, particularly older men, you should think about it. They don't have to be as obvious as the echo in the upper right that I showed. I think most people know about this abnormal strain pattern, this apical sparing that you can see if you do strain, but you don't even really need that in my book. You see increased wall thickness with the right demographics, you should think about it. There are some very characteristic MRI abnormalities that if you order an MRI, even if you don't think of it, they'll probably come back to you and say you should think about amyloid here. But again, if you've suspected it, as we'll see, you don't really need to go down the MRI route to make the diagnosis. This would be a very typical electrocardiogram. You see low voltages in the limb leads. You see a conduction delay. You see what's called a pseudo-infarct pattern with Q waves inferiorly and anteriorly. But just remember, again, you won't always see it like this. Now, this is a really important slide. So to make the diagnosis non-invasively, one critical part is ruling out a monoclonal protein because we have to make sure it's not AL. And this causes all sorts of confusion, which I'm going to try to clear up right now. So there are 3 tests. There are a serum and urine protein electrophoresis with immunofixation, what I'm calling SPI and UPI. That's, if either of those is positive, it doesn't matter if it's a trace protein. Once you have the presence of a monoclonal protein, you are done. You cannot make a non-invasive diagnosis because AL could be. Now, what caused a lot of confusion, though, is the serum-free light chain assay. So again, we all have a certain amount of free kappa and free lambda light chains swimming around the serum. The ratio is roughly 1-to-1, but you have to get into the weeds a little bit. So it turns out the bone marrow produces somewhere between 2 to 3 times as much kappa as lambda. And the reason why the normal ratio is around 1-to-1 is because the kidneys are really, really good at clearing kappa, much more so than lambda. So in somebody with normal kidney function, the kidneys are so good at clearing kappa that you actually tend to have a little bit higher lambda than kappa. However, in an older patient population, nobody has truly normal kidney function, and and some people have significant kidney dysfunction. And as you have progressive kidney dysfunction, both levels go up, but kappa goes up disproportionately. So when you look at the quote-unquote normal ratio, it's not what will come back on the lab report, which is 0.26 to 1.65. You have to raise the normal, what the normal is. I've shown in the lower right one system for saying what normal values are as EGFR goes down. This is based on a large screening program from Iceland, as it so happens. But the point is that as you start getting to 2-to-1, even 3-to-1 with kidney dysfunction, that's okay. Doesn't mean a monoclonal protein. Okay? If you have a monoclonal protein, the only way to make a diagnosis is biopsy. Do not waste your time getting a PYP scan for the reasons just cited. And where to biopsy, I would recommend just, if you have the capability of just biopsy the heart, because if you biopsy the clinically involved organ, it is nearly 100% sensitivity and specificity. And remember, you don't just say they have amyloid, you have to say what kind of amyloid, which there has to be enough to then send off for extra testing with either immunofluorescence or mass spectrometry. This was, of course, the study that led to much easier diagnosis, which was in this country, mainly what we call PYP scans, technetium pyrophosphate, takes advantage of the fact that an old bone tracer, and really any bone tracer, binds to amyloid deposits in the heart, particularly TTR amyloid deposits. It's got to be performed with SPECT, as we'll see, or you can end up being fooled by blood pool uptake. The reading is really quite simple. If you have more uptake in the heart or equal uptake in the heart, as in the ribs, it's considered a positive scan. Okay, here was the study, and everybody got both bone scintigraphy and monoclonal protein testing. Really important message here, 22% of biopsy-proven AL patients had frankly positive scans, and that's why you cannot use the scan to make an ATTR diagnosis if AL is in the differential. How is AL in the differential? Because they have a monoclonal protein. Okay, rather, this is how to use the test. If you ruled out a monoclonal protein and you had a positive scan, it got the diagnosis right in this cohort, 391 out of 391 times, or a 100% specificity. Okay, so a couple of examples. Is this a patient with ATTR amyloidosis, 66-year-old man with heart failure, typical findings, and you see the uptake, you see it's in the heart. No, this patient didn't have monoclonal protein assessment. This is a patient with AL amyloidosis. How about this patient? No monoclonal protein, and it was called grade 2 uptake. You can kind of see the heart there. It's about equal to the ribs. No, this was without SPECT. When you looked at SPECT, you can see all the uptake was in the blood pool. This is a false positive. How about this one? This is a patient who has clear uptake in the heart, negative SPI and UPI. Oh, but you see that capital lambda ratio is a little bit above normal. It's 2.1. Well, this patient has kidney dysfunction. That's okay. So this is not a monoclonal protein. You can actually make the diagnosis of ATTR here non-invasively. Okay, so do not order PYP scans, okay, if they have a present monoclonal protein. So the algorithm is very simple. The first thing you do when you suspect it, check for monoclonal protein, and then if it's normal, you move on to your bone scintigraphy. If it's abnormal, you move on to biopsy. It is really that simple. Okay, so I would say ATTR cardiomyopathy is what I call the unrare rare disease. As we saw, it's not uncommon. You should think about it in thick hearts. Those with orthopedic manifestations are the other clues up above. Again, the right workup, rule out a monoclonal protein, and if it's ruled out, then a PYP scan. If it's not ruled out, then a biopsy. And then really all patients should be offered genetic testing to make sure they don't have an inherited form. The common pitfalls, skipping or misinterpreting the monoclonal protein testing, doing a PYP without SPECT, or the biggest pitfall, of course, not considering the disease in the first place. And why does it matter? We are about to see from Dr. Masri. I will make a shameless plug as I am fortunate to be deputy editor for JACC Cardio-Oncology, and we like to consider ourselves a home for amyloidosis, and it's open access, so please check it out. And I work with a superb team here at Stanford, and always feel free to reach out to us with any questions. And now, let me turn the floor over to Dr. Masri to talk about therapies.
Later on, but we're going to welcome now Dr. Ahmad Masri. He was here yesterday. Some of you met him, but he's at OHSU, and he's the director of the Cardiomyopathy Center. Also has been involved essentially his entire career in the space of amyloid and has quickly become one of the world thought leaders. He's also one that was involved in a lot of the trial designs, and I think later on we'll have some questions about that. And he's going to talk to us about therapeutics and transthyretin amyloidosis.
Thank you. Thank you. It's great being here. It's been a great meeting, and thanks Tony and Barry for the invitation, and lots of great talks, lots of learning here. So I'll be talking about therapeutics in amyloid, and I'm following a great talk by Dr. Witteles, and you always need to be nice to him because he's the editor of JACC Cardio-Oncology, and if you're submitting papers there, it helps. So, no, I'm advising them to be nice to you.
Okay.
And so those are my disclosures. They are relevant because we're going to discuss some therapeutics, but I'm just presenting trial data. I'm not giving opinions during the presentation itself. So this is the cascade of what we're trying to do with TTR amyloid. This is a talk that is focused on TTR amyloid. We're not going to address light chain amyloidosis. It is really important to keep in mind, though, that there are lots of learning relates to light chain amyloidosis that you have to keep in mind. So the TTR protein comes out of the liver and circulates as a tetramer and deposits in an end organ. And so as you can imagine, you can address it in multiple ways. One is by going to the liver and reducing the production of TTR in the liver. One is by going after the protein, binding the protein, because destabilization is the rate-limiting step in this condition. The protein, as I mentioned, likes to go in tetramer form, and if it falls apart to monomers and then something else has to happen to make it amyloidogenic, you could give a small oral molecule by mouth that can bind to TTR tetramer and keep it in its tetrameric shape. And so that's what we call the stabilizers. And then what's been worked on for quite some time now, and still we are yet to report on it in TTR, in AL has been done few times, not been successful, is can you remove the amyloid deposits from the organs once that happens? And that's what we call fibril depleters or removers. We're going to touch base on most of these things. And so the thing that really introduced a massive change in how we think about transthyretin amyloidosis right prior to treatments is diagnosis, and Dr. Witteles told you a lot about that already. But that's really set the stage. That's happened around few years before this trial of ATTR came out. So set the stage for us to find these patients, because I still remember this when I was training. Somebody told me, why you're doing this research study? I said, I want to look at TTR amyloid. They're like, who cares? So that was the sentiment, because you couldn't treat these patients if they are past the age of transplant. And even transplant wasn't very popular for them. But ATTR in 2018 introduced tafamidis, which showed one of the largest effect sizes you'll ever see in cardiovascular therapy, because you're addressing the underlying issue. It is not trying to modulate stuff. It's going after the TTR tetramer, binding it, and preventing further accumulation in the myocardium and potentially other organs, but the primary organ is the myocardium. So showed improvement in cardiovascular outcomes, in mortality, all-cause mortality, hospitalization, and led to its approval and wide use since then. So if tafamidis goes to the problem of transthyretin itself and fixes it, why are we looking at a lot of other therapies? And you could argue that this trial does not represent modern TTR amyloidosis, and I agree with you, it does not. ATTR enrolled patients who were already diagnosed for quite some time, followed up by their doctors, and then the trial came, then they got enrolled. So these were not your typical patients that you see today. Today we try to find these patients earlier, diagnose them quicker, and find a solution for them, including treatment. But if you look at the long-term extension of ATTR-ACT, those are the patients who survived at least initially in ATTR-ACT and continued to go later on also to the open label long-term extension, you can see that on tafamidis in that trial, 50% of the patients died almost. There's some censoring obviously here. And if you were on placebo and got tafamidis introduced later on, actually almost 3/4 of these patients died. So it's extremely high rate of mortality in these patients with established disease. We have improved the outcomes just by recognition. That's why recognition is so important, because you can push that curve further just by recognizing these patients early. And so that's why a lot of these patients still die from progressive heart failure, cardiovascular reasons, and that's why we need to look also for additional ways of addressing the disease. The second stabilizer that came around is acoramidis, and now is also approved by the FDA, based on the ATTRibute-CM trial, which randomized patients to acoramidis against placebo. For the first year, you couldn't use tafamidis, but after the first year, tafamidis use was allowed, showing something similar related to mortality and these outcomes of reduction in heart failure, as well as cardiovascular outcomes. Something new that was shown in ATTRibute that wasn't necessarily shown before is that you could induce a rapid benefit in these patients. Now, is this because you identified a less sick population in ATTRibute, or because of the drug itself? We don't know. And the only way to know is that you do head-to-head trials, which I don't think anytime soon we'll see those. But at least what the message from this graph is, you should not wait until you diagnose these patients. We still see to this date some patients come to us after 9 months or 12 months of the first note stating concerns for amyloidosis, will work the patient up, and they come a year later, or they start therapy a year later. We shouldn't, because ultimately, if you've ever been hospitalized, even for an elective procedure, you really don't want to be hospitalized. And so that's the bottom line. And in transthyretin amyloidosis, hospitalizations are associated with much worse outcomes than not. So it's good to prevent these hospitalizations, identify these patients early, and initiate therapy very early. We delved deeper into this because with ATTRibute, for whatever reason, the primary outcome was related to the win ratio and to a pre-specified analysis of time to first event, but it wasn't recurrent event analysis. And we know in heart failure, we like to look at what happens to all the events that accrue in these patients. And this is essentially the curve for all these events. If you follow these patients over 30 months, obviously that's not individual patients, that's events. You see a hazard ratio of 0.5, which is almost, halving those events in these patients on acoramidis compared to placebo. And this starts also early. So the message, the bottom line is identify these patients early and initiate therapy early. We've actually looked at this at some point. We published on it a long time ago. We used to take, even from identification to getting them the drug, it used to take a month, usually, to get them everything, the paper, and in place, everything. But nowadays, we're doing it much, much quicker, because also there are a lot of programs that allows you to start these patients on a free trial for a month before, while the paperwork also is going on. Something unique and intriguing that happened in this trial, as well as the phase 2 trial, is that we observed the renal effect of acoramidis. And the first thing you think about when you think of a renal effect is safety. Is this a safe thing or not? I think the same thing applies to SGLT2 inhibitors. The same thing applies to most neurohormonal modulation in heart failure. Your first question is this just an artifact? Is it a safe thing, or is it a good thing? So we delved deep into this, and you have about 8 points reduction on GFR when you initiate acoramidis. And you can go back to this paper that just came out. I didn't want to spend too much time on it in this presentation, but this looks like a favorable thing overall. At least it's not harmful, but there is some preliminary data that it also could be favorable. Now, our job is not to stop here. Our job is to conduct more studies, mechanistic studies, to understand why does this happen and what is the outcome here. But if you look at this paper referenced here, you'll see data on microalbumin, on urine protein albumin ratio, and you'll see data on cardiovascular events being actually much less if you have a bigger response in terms of the drop in GFR. Then the third drug came around, which is the first silencer in this space to target transthyretin cardiomyopathy. Before it, there were already 3 to 4 silencers, including fitusiran itself, in polyneuropathy. But this was the first trial in cardiomyopathy, which showed similarly that you can improve outcomes, mortality, hospitalization in this patient population. And this trial allowed 40% of tafamidis at baseline. So the trial had 600-something patients. 40% of the patients at baseline were on tafamidis. And then also, of course, there were some more drop-ins during the trial follow-up. And I like this analysis by Dr. Witteles, which showed us what would happen if you looked at these tafamidis patients, censored them versus not censoring them as part of the follow-up, and there wasn't much difference there. There's a lot of papers out there on all these trials, and you have to pay attention to which outcomes being looked at and which things we're looking at. That's why we try to show you more of these data so that you can understand what the effect size is and how things looking like. This is also looking at vutrisiran improvement of survival and cardiovascular events in these patients with TTR. You can see on the left there that there is cumulative rate of all-cause mortality up to 42 months. The trial wasn't 42 months, but the first part of the open label extension was included because these patients get these long-term injections. Vutrisiran is given once every 3 months, so you get 4 doses a year, and so that first part wasn't expected to be changed in the trial and was included as part of the mortality assessment there. So this is not a Kaplan-Meier curve of actual individual trial data. This is just to show you a concept, the concept that you cannot compare these trials. Why? Because if you just imagine everything being equal, every placebo group of the subsequent trial performs better than the treatment group in the previous trial. And that's not because the new drug is a magical drug. It's because these patients are fundamentally different. Once you diagnose these patients earlier, once you treat them better, one simple thing such as atrial fibrillation, de-prescribing drug, prescribing drug, we take these patients so much more seriously now than we used to because we have a treatment. Again, back to the comment of who cares. This mentality right now changed because you can treat the underlying disease. So don't try to do, which I see all the time, like meta-analysis of these trials and trying to compare network meta-analysis and this and that. That doesn't work. And so how about combination therapy, which is a question that comes out all the time? This is the ACC-JAC expert panel statement that states there insufficient evidence of benefit of combination therapy. Combination therapy refers to stabilizer plus silencer. There are other types of theories about combination therapy. You could combine a depleter in a clinical trial with some of those. This is different. This just applies to one stabilizer and one silencer. And there is some preliminary data from Helios-B, but I think it was largely underpowered to detect if you can do this practice or not. So it's not harmful, but there is not sufficient evidence for benefit to do at this stage in time across all of your patients. All right. So in terms of symptomatic management, there are lots of principles about what to do with these patients. Sometimes, I get told that, well, just give someone a treatment, and that's all you do for amyloid patients. And that's actually not true. The first thing is confirm the diagnosis. I can't tell you the number of times patients have been on a medication for years and years and years, and they don't have amyloid. They don't have transthyretin amyloidosis. So we confirm the diagnosis. We talk to them about the treatment options, put them in a treatment. We offer them clinical trials. And I think I would argue that the most impact you can do as a cardiologist for those patients is to think about the other things, not just the amyloid treatment itself. And the other things include the fact that they have significant heart failure, some of them. They have orthostatic hypotension. They have lots of arrhythmias. And end-of-life consideration, which a lot of cardiologists don't necessarily talk about. This is something that we should own and should talk to patients about as well. And then there are some other issues of AFib, stroke prevention, and sudden cardiac death. So in terms of the heart failure treatments in patients with transthyretin amyloidosis, it's open for interpretation. You can use your own judgment, your own experience. There are no data at a level that is sufficient to make actual strong recommendations about this. However, we have some anecdotal experiences, we have some observational data, and we have some logical approaches that we do. So the first logical approach, if somebody is hypotensive, don't make them more hypotensive. So you don't have to really force sacubitril valsartan, which I've seen many times. You don't have to force it in someone whose systolic is already 85 and 80. Just, withdrawing it might actually be better. So those are the kind of the things you just make sense without actually needing to have evidence for them. And so this is a very nice paper you can refer to in Circulation Heart Failure that summarizes a lot of these principles and a lot of what's out there. The bottom line is we end up using a lot of SGLT2 inhibitors and a lot of MRAs, not because we have strong evidence they improve survival, but because they actually do improve how patients feel. And that's one of the objectives of treating patients. If you, at this point in time, you don't have something to use to make these patients feel better, you use what you have available for you, which is SGLT2 inhibitors and MRAs. And SGLT2 inhibitors also reduce the use of diuretics in these patients. They make them more stable usually. And so it becomes easier to manage them than them being not on it. Question, could it be just an expensive diuretic at this stage in time? Maybe. That's a maybe because we don't have enough randomized clinical trial data for this. But regardless, it does make management of these patients easier, and patients do feel better. You have to be careful in elderly patients. There's a very nice trial of dapagliflozin in aortic stenosis referred for TAVR. You can use those adverse events from that trial as your guidance. It does cause some dizziness in these patients, elderly patients. So just be careful about the use of SGLT in really old patients above 80 and 85. Be mindful that it can cause some side effects and keep an eye on that. So beta blockers, usually they're not very useful as a primary drug. There are indications for it. Try to be mindful on a case-by-case basis on when to use them. You shouldn't be using them for the sole purpose of improving function. ACE inhibitors, be mindful of the hypotension. And then we spoke about MRAs and SGLT2 inhibitors already. So what's in the pipeline? And I'm going to move a little bit quickly here. So CardioTransform is a trial of a silencer called eplontersen that is injected with an auto-injector subcutaneously once a month that can be self-done. It's approved for polyneuropathy, but this is a trial for cardiomyopathy. Largest trial on amyloidosis to date, Transthyretin. 1,400 patients were enrolled in this trial, open tafamidis. And we now know that almost 60% of the patients had used tafamidis or maybe acoramidis, but likely it's just tafamidis at baseline. And an additional 20 to 30% started tafamidis during the trial itself as well. So north of 80% of these patients were treated already, and you're following them up to 140, 160 weeks in the trial. And so why am I alluding to all of these things? Because my plan was to show you the baseline characteristics and tell you that we'll learn more next month during ESC, but there was a press release about this trial, I think now yesterday, that showed that at least revealed that the primary outcome was not met. And the primary outcome of recurrent cardiovascular events and all-cause mortality or cardiovascular mortality was not met. There was kind of in the print of that press release that the monotherapy group had a point estimate of, if I remember correctly, 0.71. So alluding to the fact that the monotherapy group did derive benefit. But remember, the overall trial is the overall trial. So the bottom line is the primary endpoint was not met here. We have to wait for ESC next month to see what the data look like. I'm going to skip over the baseline characteristics from that trial. The second treatment that I want to talk about is permanent, or what we think is going to be permanent, silencing of TTR by administering a gene editing therapy. So this is using a CRISPR-Cas9 platform. The trial is ongoing called Magnitude. We already have data in small number of patients out to 3 years showing persistent reduction of TTR north of 90% in these patients. And so this is the trial called Magnitude. Again, single infusion. I need to update that number. It's not 765 anymore, so I need to update it. But the trial was put on hold for a few months because it's rare, but some patients can have liver injury from the drug itself. And so there was a need for developing of mitigation strategies as part of the trial to do that. And so the trial now is up and running again, and if I remember correctly, 600-something patients had already been enrolled in the trial, and it continues to go to this date. Triton-CM is the third silencer that is now being trialed. In theory, it's the fourth silencer because patisiran was also trialed, but patisiran did not get approval by the FDA, so that was discontinued. Nucresiran is the third silencer that is being now trialed in a trial where the objective of the trial is to improve cardiovascular outcomes. It's given once every 6 months. Triton is ongoing right now. There is a CM and a PN trial for Triton. And the thought process is that this is going to be a more potent silencer. So you're going to have more than 90% reduction of your TTR. Whether that matters or not, nobody knows. So that's why I'm also excited about these trials, because it's an important question to answer. Does 70 versus 80 versus 90% matter in terms of silencing? We don't know. And this is a whole host of fibril depleter trials. There is a lot of sadness in this table, where you've had a lot of clinical trials in AL, which again, we don't have time to talk about it, but it's a really important disease for cardiologists because you're the front line of identifying half of these cardiac AL patients. But a bunch of these were negative. The anselimimab paper just came out showing a positive kappa subgroup, but there's a lot of work there to be done if it will ever become available. And we have multiple trials in cardiac TTR amyloidosis that are ongoing, so consider sending your patients or enrolling them in these trials if they want to. So these are my conclusions. There have been tremendous developments in TTR amyloidosis. The clinical trial results and design should be interpreted within the framework of the changing natural history of this disease. It is not a simple positive, negative, or effect size is massive or small. You really, truly have to think about those changing things related to the natural history. We have 3 approved therapies in the United States for cardiomyopathy, and we have 4 approved therapies for polyneuropathy. And then, as you can see in my slides, already outdated because I said cardiotransplant should be reporting soon. And then heart failure therapy's role in TTR remains to be defined from an evidence-based perspective, but you can use your clinical judgment as you go. Thank you.
Case to both Ron and Ahmed. And I'll encourage you all to think about questions because we'll have an opportunity to ask questions. And also during the case presentation, if you have any questions, please come up to the mic. And also, there's about 50 plus people that are on virtually. So thanks everyone for sticking through this. We're almost there. But the case presentation, it's not meant to confuse anyone. It's really trying to highlight some of the principles that we heard about. And I think it's going to be a little bit important for us to be somewhat provocative with the way we approach treatment because that is something that we deal with, that we have to discuss with our patients. So these are my disclosures. We'll go over a clinical history and presentation. I'll go over the diagnostic evaluation and confirming the diagnosis, importantly, imaging and the exclusion of light chain amyloidosis. We'll discuss treatment for this patient and disease-modifying therapies, and then lastly, I'll close with key takeaways. So let's talk about the patient. This is a 72-year-old gentleman who was referred to me not that long ago, a couple of months ago, and he's had progressive exertional dyspnea for about 12 months, very fit up until recently, and he has class 2 symptoms. He notes that he has more fatigue and decreased exertional tolerance, and he attributes this to just aging. He's been very active his entire life, performing long-distance cycling, and also has completed multiple triathlons. The most recent one was about 2 years ago. He's been hospitalized twice in the past year for decompensated heart failure. He was seen in the emergency room with shortness of breath and evidence of volume overload, and because biomarkers were abnormal, they kept him in the hospital, even though he just had modest amount of volume. He also notes that for essentially his entire life, his heart rate has been on the low side, and he notes his heart rate now is spiking. He'll have these paroxysms or these episodes of elevated heart rate that self-resolve. He has more shortness of breath when he has them, but they're not particularly associated with any exertion or any specific activity. His past history is bilateral carpal tunnel syndrome, symptoms at least that started in 2021. He's had multiple knee surgeries, and he's been told essentially this is just due to overuse, being a triathlete and also a cyclist. And as I mentioned, his past history at least reports sinus bradycardia. He's had electrocardiogram for his surgeries. He was cleared for surgery, but they noted that he had sinus bradycardia. Again, that was attributed to his fitness level, and I've already mentioned these episodes. So any initial thoughts, Ahmed and Rana, about this patient's presentation?
Well, so I mean, of course, the orthopedic history, particularly with the late presenting bilateral carpal tunnel, is notable, and he certainly fits the right demographics for the disease we're talking about. I think clearly all of us would want to work up both the rhythm disorder with some sort of ambulatory telemetry, and of course, he's going to get an echocardiogram, maybe cardiac biomarkers.
All right. So this is some of the exam and findings and also his labs when I saw him in clinic. His blood pressure was 104/68, heart rate of 92. His jugular venous pressure was about 8 millimeters of mercury. Nothing remarkable on lung exam. He did have an irregular heart rate, but no murmurs. What I noticed, and actually no signs of volume overload really, but I did notice bilateral thenar atrophy, and then with provocation, you could elicit like trigger finger-like signs. His NT-proBNP was 1200, fifth generation troponin was 50, creatinine of 1.4, and a hemoglobin of 15. Any comments that, I know it may seem very obvious, I'm not, again, trying to trick anyone, but I just want to
the troponin, again, just highlighting from what I was speaking earlier, this chronic low level elevation in troponin should be a tip-off as well. And of course, it more often than not prompts an ischemia workup, which is probably not what's needed here.
And you want to keep an eye on that creatinine of 1.4. If this is a healthy athlete, why do they have a creatinine of 1.4?
That's fair, yeah. And NT-proBNP a little bit higher than I would expect with someone that doesn't have clear evidence of volume, although we may be able to blame some of that on the creatinine. Here's his electrocardiogram.
As expected. So anyway, I mean, the atrial fibrillation is obviously as expected from the history in the exam. I think the point here, if we look at the voltages, so, again, you see actually quite prominent voltages on the precordial leads, but you see relatively low voltages, wouldn't certainly come close to meeting criteria, but in the limb leads, but if we get an echo and we see massively increased wall thickness, then we would say that there is some discordance.
Okay, so let's go on to some of the diagnosis, and I will also share that this patient had already had the evaluation for amyloidosis began before I saw him, so some of the work was already done. This is, I don't have loops of his echo images, but this is his parasternal long axis and his apical four-chamber. And as you can see there, the IV, the intraventricular septum measures at 13 millimeters, posterior wall at 12 millimeters.
So thinner than most, I mean, I would say by the time somebody develops symptomatic heart failure, particularly men, tend to be a little bit thicker than this, but his AFib is probably what prompted the symptoms as well. So.
Okay. All right, so if you recall Ron's discussion on the diagnostic algorithm, this is what was already available for the patient. So he had a bone scintigraphy that's shown there, and maybe, Ahmed, if you can interpret what you see there.
Yeah, so this is a SPECT scan with planar. Planar on the left, the SPECT is on the right, and we get a single cut of the SPECT, but it looks like there is diffuse uptake of, I'm assuming this is PYP, or looks like PYP more than HTP, but it could be either. And one intriguing thing is obviously you have to go through the SPECT slices, all of them, but it looks like there is more tracer uptake in the mid and the apical segments over the basal segments, unless this is really foreshortened and you're just starting from the cranial segments there. And then the RV looks like also is potentially involved there.
All right, and the patient actually brought this to me and said, I'm here to start treatment, and he already had an idea of what he wanted. So how do you counsel these patients? I'm sure you probably see this just like I do, patients that come in with these tests already completed and asking to start treatment that day. And is it appropriate to start based on the information you have?
No, he needs monoclonal protein rollouts, but that's quick. So I'd say I would certainly discuss treatment at the first visit, because this is overwhelmingly likely is going to be ATTR, but I would wait to prescribe it until the monoclonal protein testing was back.
There are some unresolved issues. I'm not sure that you're trying to make this a special case or not, but the EKG is not a typical EKG of someone. It can be an EKG of an athlete who then developed TTR, that's true. But in general, you just want to keep that in mind. This is not the most classic picture of TTR. So I would like to look at these images more. And then back to the creatinine story of 1.4.
1.4, yeah.
Also, the wall thickness is not that much.
Yeah.
And so
I
you
would
said
agree
that
with
he's pretty symptomatic. And
He's
so,
fairly symptomatic,
Yeah.
and particularly when he's in atrial fibrillation. Although I will say he's still cycling, just not
Okay.
competing when he cycles. So just as a reminder, this is the diagnostic algorithm that I think you've already reviewed with Dr. Witteles. It's still important to go through this exercise in your head. So you have a clinical suspicion, heart failure. Often we describe it as preserved ejection fraction, but mid-range or low EF can still be seen with amyloidosis. Maybe it's an echo or an MRI that gave you the first clue that there may be an amyloid cardiomyopathy, and it is requisite to first rule out a monoclonal protein. You already heard about the 3 tests that we get: immunofixation, both serum and urine, and also serum kappa free light chains. Because we know that MGUS is prevalent in this patient population, we're talking about specifically age-related or wild-type amyloid. Even if you see a monoclonal protein, it doesn't mean that you refer to the hematologist and don't see them again. We still have to follow that through, because more often than not, you will see MGUS with TTR. And if you refer them to the hematologist, they do a bone marrow, they maybe do a fat pad, and they tell you there's no AL and we don't finish the evaluation, we potentially delay or miss the diagnosis. And then, of course, if you have the appropriate negative diagnostic workup for a monoclonal protein, we'll do bone scintigraphy. So, of course, I'm showing a case that flipped the order. We don't have that done yet. And then I won't go over the positive criteria, as you guys already saw that on an earlier slide. So just as Ron, as you mentioned, I asked him to go to the lab that day. I told him we can get the results fairly quickly, sometimes overnight, to get immunofixation. And serum and urine both showed a monoclonal protein that types as IgG kappa. His serum free light chains are listed there: kappa of 80, lambda of 19.8, and a kappa lambda ratio of 4. We can attribute some to CKD, but because there was also a monoclonal protein a little bit higher than I would have expected for modest rising creatinine, the results prompted a biopsy, which was Congo red positive, and then we reflexively will send a Congo red positive biopsy to the Mayo Clinic so we can do tandem mass spectrometry. We identified that this was ATTR or transthyretin type amyloidosis. Any thoughts?
Yeah, I mean, so it's a good example. So again, even if his free light chains were completely normal, which they are not, just by having the positive IgG kappa on the SPI, that's enough. You cannot use the bone scintigraphy anymore. But you can see that the kappa to lambda ratio, I said, if you have a negative SPI and UPI and you have a very mild predominance of kappa, that's okay. 4 is not okay. So either one of those would have had to say, okay, we can't use the PYP scan, we need to move on to biopsy.
And we talked about the 3 tests: serum urine and serum free light chains. Every now and then I have a patient that, for whatever reason, doesn't do it, maybe lives far away, can't get it done at Quest or LabCorp for whatever reason. How strongly do you push for the urine part?
So, okay, so why do we do the urine? So the serum is mainly to look for the whole monoclonal antibody. Occasionally you can see light chains, but that's not what it's used for. The whole reason for the urine is to look for the light chains, because light chains are concentrated in the urine. So you say, but wait a second, we're looking for the light chains with the serum-free light chain assay. Why do we need it? And the answer is that the UPI will say definitively clonality if it sees it there. And so when you have cases that are borderline, let's say you have a kappa to lambda ratio of 2 or a kappa to lambda ratio of 0.5, and you're saying, we might let this go, but not if you get a UPI back that's positive. So I would say, would I ever rely just on SPI and serum-free light chains? Yeah, it's going to catch the vast majority of cases, but ideally you want to do the UPI too.
And so I didn't put this there, but the Mayo Clinic did tell us it was, they didn't see any amino acid change that would suggest a mutation. It was consistent with age-related or wild type. Would you still send genetic testing in that case? And can you tell us, if so, why?
Yeah, I would. So it's very good, the mass spec for detecting mutations, but it's not perfect, and they will note the disclaimer on that, and some mutations in particular it's not perfect with. You can, it is easy with company-sponsored free testing that can be done, And you send it to their home, a kit, and they spit in it and send it back in. So it should be offered to all patients. But yes, this is overwhelmingly likely going to be wild type.
Okay, so let's go to treatment.
There is one point though, Tony, that
Yes.
in this scenario, other biopsies are not very useful because this is an older patient and you're thinking about the heart itself, correct? And so, I see this all the time that people go for other types of biopsies. They do kidney, they do fat, they do bone marrow, for 6 months before you go to the heart. But the reality is, if you have an older patient that is at risk of TTR as well, it's just the heart that's going to be the most definitive.
Yeah, I agree with that, and I think we can do a biopsy with relatively low risk. And if we're thinking TTR and not really thinking, I didn't think this was light chain. Otherwise, I probably would have been okay with a surrogate biopsy site or a fat pad. But I agree with you fully that that's why we pursued a heart biopsy. Treatment. So we discussed the therapies that you already highlighted, Ahmed, tafamidis, acoramidis, and vutrisiran. The patient actually, as I mentioned, came in and already was asking for acoramidis based on discussion with other providers and their review of the literature. They actually asked for it because of a specific actor that's on one of the ads. So in addition to disease-modifying therapy, they had already looked up essentially what was available, and they also asked to participate in Transthyretin, thinking that dual therapy. They didn't ask me for dual therapy, although my opinion is what you stated is that there's not sufficient data for that. They wanted to participate in clinical trials, specifically Transthyretin. The idea of having less frequent dosing of medications was something they were interested in. We started on SGLT2 inhibitor, and we discussed the pros and cons and the potential benefit, particularly with this patient having symptoms that I attributed to atrial fibrillation, and he underwent cardioversion. We restored sinus rhythm. And then, and I'm curious if you guys can comment on all these things, he also requested or asked about left atrial appendage occlusion device. And my thought, after reviewing pros and cons, and what I recommended to him was that there is a paucity of data that atrial appendage was not the only place where he could develop thrombus. And with someone who had an acceptable risk for anticoagulation, recommended he continue on that. So I'm curious to hear your thoughts on how you would approach this.
Yeah, I'll start, I guess. So, of course, I agree with the SGLT2 inhibitor. I certainly agree with restoring sinus rhythm. I would actually talk seriously about sending him for AFib ablation. I think it has been, in my opinion, transformative for a lot of patients with this disease in the era of pulse field ablation. And there's a nihilism that sometimes you will encounter with electrophysiologists because the atria seem so diseased. But I can tell you, in the era of PFA, it works more often than it doesn't. And here's a perfect candidate who is not that ill, but is clearly affected by his atrial fibrillation, or at least very likely is. And I also think that the antiarrhythmics that get used are often quite poorly tolerated. It's my biggest quarrel with the guidelines that were published about this that says amiodarone is generally well tolerated in this disease, which there is not evidence for, and I just disagree with.
What about dofetilide?
I'm sorry?
Dofetilide, what are your
No, well, look, he's got kidney dysfunction, so I would worry about that some, and he's certainly prone to more kidney dysfunction. But again, I would say first line in general in heart failure should probably be AFib ablation, and in my mind, even more so in this patient population. So I agree with you. I would not be enthusiastic about left atrial appendage occlusion in him unless there was a real need to get him off anticoagulation.
I'm glad you said that because he's going to see my colleague Dr. Sue in the back, who you heard of that no atrial appendage occlusion. That's consensus today. So we'll just pursue AFib ablation. Dr. Masri, any?
No, I agree with everything Ron said. Unless there is a very strong reason to pursue a left atrial appendage occlusion, I don't think you need to. And then the other thing is that it's not just that a problem of the thrombi arising from other places. It's also a problem that sometimes if this progresses as a disease and you want to keep him in sinus rhythm, if you do a TEE, a lot of the times you end up with also thrombi, and then there's just like a circular argument. And so just if there's a reason for that, otherwise, anticoagulation.
Now, so what are your thoughts on patients come in and they ask for a specific drug? You shared with us, Ahmed, that all of them work. We can't compare trials. Is that okay just to give them whatever they ask for, or do you arm wrestle with them and try to convince them that one is better than the
No,
other?
I just educate people. I don't mind if someone wants a specific drug. If the 3 drugs are equal, which we think at this point in time, there is not enough evidence to give a strong recommendation that one drug is much, much superior than the other. Maybe there are some attributes and properties of one drug that looks maybe better than the other indirectly, but they're not compared together. And so I think we offer people all 3 drugs, we educate them about it. The biggest issue that happens with that is that people come, they've read on Facebook a million things that are half wrong. And that's why we try to educate them. We tell them what every drug is, what it does, what comes out of it. And then after that, all is fine. It's fine to do that. The one thing that I don't do much of is combination therapy. Like there are people who come and say, I want to be on this and this and that. And I'm like, well, it's hard to do all these things. And so, yeah.
So, yeah, and I'm glad that he didn't ask for combination therapy. I have the same opinion. Ron, we just have the press release, so it's relevant and it's open for debate even though we don't have the full presentation. Does the press release convince you that it's futile to consider dual with a silencer stabilizer or more to come?
No, it certainly doesn't convince me. I want to see the full data set, but am I less enthusiastic today about combination therapy than I was 2 days ago? Sure.
Yeah, so we're talking again about eplontersen, the press release yesterday that the primary endpoint was not met. But I want to come back to that a little bit because we have 3, or at least therapies. And again, please, if anyone has questions, come up to the mic because right now it's open discussion and questions for our panel. We are preaching to the community that we need to look for this disease. Treatment should be started earlier. We're going to move this disease away from amyloid centers of excellence or amyloidologists to some extent, right? So how should we be thinking about the therapies? What would you recommend for someone that maybe doesn't spend their time dealing with amyloid in terms of how they pick their first line?
I don't really care, as long as they get the diagnosis right and they get started on one of the 3 therapies. As Ahmed was saying, we have 3 really good therapies. And there's a lot of hand-wringing about which one is better, and I agree, we don't know the answer. What we do know is all 3 work really, really well. And so we should be putting, in my mind, all of our efforts in getting patients diagnosed, making sure that the diagnosis is accurate, and then getting them on therapies, and worrying less about, should it be this one or this one or this one, because there's 3 good options.
And we have a question here, Neil.
Neil Dixit, UCSD. Great talks from all of you. My question's in regards to how to interpret and manage a grade 1 PYP scan. Let's say you have a patient that has suspicious features for ATTR amyloid. You've ruled out AL amyloid, but their PYP is grade 1. Do you push them for cardiac biopsy, or is the MRI helpful? Is there any value in just empirically treating? Do you repeat the PYP at a later date? Just kind of wondering your approaches to that.
So that's a good question. So it's not normal to have any uptake on these tracers in the myocardium. So the grade 1 wasn't because it could be normal if it's a grade 1. If it's a true grade 1 and it's not blood pool or any of that stuff, there's something going on. But the problem is that it is not specific. So there is no specificity for TTR amyloidosis when you have faint, very little uptake there. That's where the grade 2 and 3, especially 3, even 2 sometimes, here and there, but the grade 3 is just in the absence of monoclonal protein and the absence of some zebras like hydroxychloroquine toxicity, some very inflammatory cardiomyopathies, the recent MI, maybe be careful about pericardial effusions, but in the absence of these, there's really nothing else that will cause that. That's the principle. If you have grade 1 faint uptake, it just then depends on your pretest probability. If the pretest probability is high, then you probably should sequence the TTR gene, because if the TTR gene is positive and you have a grade 1 and you have typical features on echo, you could do an MRI as a safety blanket, but you're done. But if the TTR gene sequencing is normal, you don't have any other alternative diagnoses, then you should go to, one option is to go to biopsy. A second option, if they're doing fine and they have minor structural changes, is just to repeat their workup in a year, for example. Because if they're not symptomatic and they're not having heart failure and they're not having established amyloid diagnosis, nothing bad is going to happen in a year. I personally typically don't wait. I just like to close the loop on everything. So if my pretest probability is low, I go for an MRI. If my pretest probability is intermediate or high, I just go to the biopsy.
I know we have another question there.
Yeah, these are two quick ones. I may have missed something, but what is the SGLT2 inhibitor for in this gentleman?
For his symptomatic heart failure. So, I would say two things. One, we heard, including from Dr. Yancey just before, about how effective SGLT2 inhibitors are just in general in HFpEF and HFrEF. As Dr. Masri was saying, there's, of course, no specific randomized clinical trial in the amyloid population, and probably never will be, but there's pretty good observational data now that does show that the amyloid patients who got treated with SGLT2 inhibitors, even when you try to match them, do a lot better. And I think all of us who see these patients anecdotally will say that rings true. So I would say for any heart failure, ATTR heart failure patients, they should be on an SGLT2 inhibitor unless there's a clear contraindication.
Okay, good. And then the other thing, just out of curiosity, a trial design for the nucresiran, what would happen with his current therapy? I'm assuming it wouldn't be versus placebo randomized, so I'm just curious about the trial design.
It's versus placebo, but you can be on background stabilizer. So you are allowed to have standard of care therapy.
Okay.
Barry, you have a question?
I'm just curious if your choice of medication would differ if the patient had mild to moderate neuropathy.
So great question. I would say it would depend wild type versus variant. So wild type patient, and there's a little bit of debate about this in the field, but I'm not a believer in ATTR wild type polyneuropathy. The challenge is neuropathy is common in older patients for all sorts of reasons. But the bigger problem is patients get diagnosed with neuropathy from nerve compression, which are two different things. So you have spinal stenosis, you will have some nerve symptoms. You have carpal tunnel, you'll have some nerve symptoms. That's not neuropathy. For wild type, it personally would not affect my prescribing habits. For variant patients, absolutely it would. And it is first off, the only approved agents for ATTR polyneuropathy are silencers. And I would say the only real stabilizer trial to date with polyneuropathy was actually the first trial in this disease of any note of tafamidis that didn't actually reach statistical significance. So I would say in a patient who has true variant mixed phenotype disease, vutrisiran would make sense as an agent that is approved for both.
But just to follow up, do you think that trial that you're referencing with tafamidis, was it trial design also?
So yes and no. It was actually an interesting trial. They screwed up by saying, back then, this was only in variant patients, of course, and it was mainly that V30M mutation. And so the only treatment available at the time was liver transplants. Because you're taking out the liver that produces the variant protein. So the mistake they made is they said, if you get a liver transplant during the trial, we're going to basically count you as having failed, as met the endpoint. Well, 69% of patients were on the liver transplant list when they entered the trial. And getting the transplant had nothing to do with the drug working or not. Their number came up on a list. Now, by pure happenstance, it was balanced between the two arms who got transplants, but it lowered the power, and the p-value was literally 0.06. So did the trial design likely sink it from a powering standpoint? Yes, but what was the p-value for the silencer patisiran in its polyneuropathy trial? How about 10 to the minus 24th? in a 225 patient double-blind randomized placebo-controlled trial. So I think the evidence is clearly stronger for silencers when it comes to polyneuropathy.
And the Europeans had a lot of experience as well with this. And, we were talking about this right before this session, is that, even in the US, we had small experience with this because of misdiagnoses. They come on a drug and you see them progressing. But in Europe, if you speak to any of the European centers who have used hundreds of patients, put them on tafamidis for neuropathy, and then had access to the silencers, they would tell you it's different.
Okay, at the risk of being very unpopular, delaying the cocktails, quick question, we can talk about it after. On the discussion of amyloid and aortic stenosis, I didn't hear mention of low flow, low gradient.
Oh.
I feel like I was paying attention.
Oh, no, I said it.
Oh, you did?
Yeah.
So the incidence
You weren't
of
paying attention.
low flow, low gradient, okay, I apologize. Just wondering, again, the incidence that you see amyloid in low flow, low gradient versus high gradient, normal flow.
Yeah, so of course you can see it in both, but the characteristic is the low flow, low gradients. Why? Again, because the stroke volume is particularly small because of the degree of wall thickness, and obviously the myocardium is abnormal. So I would say unless you are going to institute universal screening in patients referred for transcatheter aortic valve replacement, which frankly is not unreasonable based on the data, but I don't think most places do, that would be certainly one of the red flags that should trigger it. Yeah, thanks, Arena. I know, that is my problem, and I still didn't quite finish on time. Shame on me.
Yeah, and just one thing I was gonna say but it cannot be used to rule out the disease, because if you look at the primary papers out of this, we've put one with Colombia now almost 10 years ago, that about a quarter to 30% of the patients had normal flow or high gradients. Yeah. And so yes, it's the high risk population, but don't use it as a rule out criteria. It's better to also look at the degree of LVH, and the key point is the lateral basal segment. If the lateral basal segment looks like the one that Tony showed, where it's thickened and it doesn't shorten without GLS, without strain, just that lateral basal segment, that's a high red flag for a tissue problem. It doesn't have to be amyloid, but it's a tissue problem in aortic stenosis.
From a cardiology fellow kind of standpoint, we're always talking about like early diagnosing, all of this, but there's a point, I guess there was a position statement that you're an author last year. It was on disease progression. And so I was kind of curious, based on your experience, like when things are, I don't know, you're increasing your diuretic, the NT-proBNP is going up, they're not able to walk, do that 6-minute walk test. When do you decide, okay, this is not working, I'm going to change therapies, when we're saying all the therapies are kind of comparable?
Yeah, thanks for that question. It's a good one, a really important one. So how to define progression? Well, first off, when we say progression, what do we mean by progression? Do we mean more TTR amyloid deposits, or do we mean their heart failure has gotten worse? And the truth is, it's probably usually the latter that we're referring to, not the former, at least in patients on therapy. We put out, the group of us who authored that, put that out mainly to try to update criteria that had been put out in 2021 that highly emphasized imaging, or at least that was a significant part of it. And the data didn't bear that out very well subsequently over the following years. And we tried to pick factors, that, specifically ones that were evidence-based in the sense that large cohort studies that showed that these changes correlated with worse heart outcomes. We were also very careful in the text to say, because somebody progresses does not mean that their amyloid therapy is not working. It means their heart failure is getting worse, which is really what all those things were. And that it should not be axiomatic that because their diuretics went up, or because they had a heart failure hospitalization, or their 6-minute walk went down, or KCCQ, et cetera, that it means they need to change therapies. And we do not know that. Biochemically, all 3 approved therapies probably, quote unquote, work in every patient who takes them. If they take a stabilizer, their TTR is probably largely stabilized. If they take a silencer, their TTR is probably knocked down somewhere 80, 85%. It's different than, say, a patient with cancer who gets a cancer therapy and their tumor shrinks, and then over time it develops resistance and starts getting bigger. That's not what we're talking about. Now, I will say it is human nature and not unreasonable to say, I am on X therapy, I feel like I'm getting worse, there's 2 other options I want to switch. And I think most patients and many healthcare providers will do just that. And it's not unreasonable, but it's also outside of anything we can be confident in.
All right, any last words, Ahmed?
No.
All right, well, I think we're going to close there. Thank you for a very engaging session to our speakers. We have one more raffle and then cocktail hour, so I'll call out the